Hello everyone, welcome to our Interventional Radiology channel. Today's case is that of an emergency embolization for a lingual artery pseudoaneurysm in an operated carcinoma larynx patient. Patient is a 41 years old diabetic male, diagnosed with carcinoma of the larynx since 1.5 years. He underwent radiotherapy first, followed by surgery about a month back, in which total laryngectomy with neopharynx formation was performed. Here is the first CT. Circumferential mural and mucosal thickening involving the supraglottis, both true and false vocal cords, anterior and posterior commissures with luminal narrowing, and showing heterogeneous enhancement on post-contrast study. This is the second CT after radiotherapy almost after 6 months. Compared to previous scan dated December 12, 2019, there is mild improvement, however significant changes are not seen. Patient underwent tracheostomy for difficulty in breathing about 9 months after the second CT. Post-tracheostomy CT shows irregular peripherally enhancing soft tissue attenuating infiltrating lesion, involving anterior commissure, false and true vocal cords with significant luminal narrowing. The disease appears to have increased. Here is the lung window, which shows no lesions at this point of time. Patient was operated and subsequently put on TPN. He was started on NGT feed and sent home with tracheostomy and NGT in situ. However, he reported after a week of discharge with a pulled-out NGT. At this time patient was found to be COVID-19 positive. His multiple tests, including the last one 5 days back, were negative even though the markers were raised. However, he was clinically stable without any features of COVID. He was then referred to radiology for NGT insertion. We can see an irregular space in the anterior neck, with irregular contrast filling, along with a pharyngocutaneous fistula with contrast egress. Note the guide wire is going into this false space. Note the guide wire going as far down as T4-5 level. The middle panel shows the true entry into the esophagus. Subsequently, an NGT was inserted after exchange of the hydrophilic guide wire with an Amplatz extra stiff guide wire. Patient was started on NGT feed, however he has repeated vomiting. On fourth day, he had sudden massive bleeding and was resuscitated. Then a CT angiography was done, which showed a large hematoma in the oral cavity with a pseudoaneurysm from the right lingual artery. The lung window of chest showed classical lesions of COVID-19, that is peripheral irregular opacities with central hypodense core, as well as basal infiltrates and linear opsities. Patient was taken up for urgent DSA, which revealed the pseudoaneurysm from lingual artery trunk. After superselective microcatheterization, glue embolization was done with lipiodol mixture with successful parent vessel occlusion. Patient was sent to HDU, and continued on medical management. A feeding jejunostomy was subsequently performed. He has been doing well since then. This concludes today's case.